Good afternoon, everyone. Myself, Dr. Sheikh Adnan Yusuf from West Bengal, Kolkata. I am the senior resident of the Department of General Medicine, Jagannath Gupta Institute of Medical Science, Boj. And with me, renowned professor, eminent teacher, Professor Dr. Sibendu Ghosh, and Vice President of the API governing body. Along with me, Dr. Rakhi Sanyal, Associate Professor, Department of General Medicine, Jagannath Gupta Institute of Medical Science, Kolkata. And today we are having a discussion with sir and madam. The first discussion will be clinical deterioration in medicine. This is a very important topic. Sir is working on it for many days, and sir is a renowned clinician. Sir believes in the clinical medicine and has worked upon this for the last decade. For the last few years, during the COVID pandemic, it has been noticed that we the physicians are relying more on the investigation and telemedicine. And for this, we are losing the clinical medicine from our practice. And sir will enlighten us with how to apply clinical medicine more and more so the harassment of the patient party get reduced. Sir, will you please enlighten us?
Thank you, Adnan, for your nice introduction of us and will approach to the clinical medicine. What is happening in India that we are bombarded with the technological advances, and most of the physicians, even in our country, are relying on the investigations and on the technological acquisition that is available in their armamentarium. They are using it, and most importantly, they are forgetting the historical part of the disease as well as the clinical examination. Most of the time they are losing it. Most of the time the corporate, particularly the corporate hospital doctors, what they do not see the patient, they do not talk to the patient relations, they do not talk to the patient itself, they just go suddenly to the investigation, and after having the view of the investigations, they start treating the treatment. So that is our basic crunch of problem. The treatment should be directed to the patient's problem. Treatment should be for the patient, should not treat the investigation. That is our basic content in this page. There is a plenty of literature on that. 70% of the disease can be diagnosed only by having a good history taking. Another 10% by good investigation. And 5 to 10% you cannot have a diagnosis. It is most of the time undiagnosed throughout their life, or patient may die. But 70% in our country, where people cannot afford the medical, cost of medicine and other medical equipment, what they can do, doctors can do it in a better way, and there are plenty of avenues. If the younger doctors are very much enthusiastic about this very basic part of history taking, proper clinical examination, and not only that, after that again re-examination, history taking, examination, and if it fails, then we can go again re-examination of the patient so that we can get better clue for treating this patient. So that is my contention. Go more clinical and more clinical, less technological. Don't treat the investigation, treat the patient. Thank you very much.
Thank you, sir. We'll keep it in mind that treating the patient and finding out the history and clinical examination is very important before we rush to the investigation. In line with that, we will move on to the next discussion with Dr. Rakhi Sanyal. For the last decade, India is having a very rapid urbanization, and for that, the scrub typhus, we are getting many of cases of scrub typhus, many of them are getting unnoticed, so the patients are suffering. Ma'am will discuss how to diagnose and how the scrub typhus has become a menace to us and the physicians.
Thank you, Adnan, so much. And I really feel privileged, and I'm so happy to share the same platform with our eminent teacher, academician, Professor Dr. Sibendu Ghosh, and together with my brilliant student and resident Adnan. Now today, yes, Adnan, it is definitely true that previously scrub typhus was limited to mostly the rural areas, but nowadays with urbanization, we are getting cases, quite a number of cases in the different sporadic areas of urban areas. And northeast area has shown a resurgence in this scrub typhus incidence. Together with the prevalence is also rising, and so we should be, and together with that actually since this scrub typhus is a featureless, because it doesn't have a specific feature of its own, so it is very difficult to diagnose if we are not scrub typhus minded. So when a patient comes to you with fever and together with some vague symptoms, say like respiratory symptoms, GI symptoms or neurological symptoms, we have to be scrub typhus minded, because it can mimic the features of other disease, other viral fevers like dengue fever, malaria, leptospira and many others, like maybe non-infectious diseases also present like with the same symptoms. So we clinicians always have to be scrub typhus minded. And first and foremost, we can always send the IgM to be done, like scrub typhus IgM. We get kits for that, and it's very easy to do it. So that, because this disease is highly curable, and only doxycycline in pregnant woman we can give azithromycin, but it is highly curable if it has been diagnosed quite early in the disease. But very unfortunately, this is not the sequelae always, because we do diagnose later, and with that the complications arise, and the complications can be real devastating. It can affect many areas, like the very common is the ARDS, in which we have seen quite a lot of mortality. Morbidity is definitely there, but people do succumb to the disease. And second comes the renal failure. We do get renal failure cases. There is meningoencephalitis, there is MAS, that is the macrophage activating syndrome. So all these add to it the burden of the disease, and multiple organs are affected, because this is basically a vasculitis which is affecting multiple organs of the body. So and it is definitely curable. So we physicians have to be more dependent on the thing that yes, we can get scrub typhus even in the urban situations, and it is quite common, it is increasing, and just a bit of diagnosis, which is very simple, a kit can make us diagnose the case and treat the case effectively and prevent the mortality and morbidity.
Thank you, ma'am. With this discussion, we as a resident find more and more cases in the OPD, and with the lifestyle modification of the Indians, the non-alcoholic steatohepatitis and its complication, patient landing up to cirrhosis even. Dr. Professor Sibendu Ghosh sir will enlighten us, and we'll have a short discussion about India and its new disease, the new enemy of the lifestyle modification, non-alcoholic steatohepatitis.
Nowadays, what is going on in India, more than 40 million people in India is diagnosed as diabetic, but they are not treated properly. A large population do not know whether they are diabetic or not. They are diagnosed when they are in the emergency setup and somehow diagnosed in the hospital only. But the whole scenario of a metabolic syndrome, where liver, heart, kidney, brain, all are being affected. In fact, nowadays we are seeing that metabolic disorder is a liver first, heart second, then brain and other organs are affected. So it's a total hollow metabolic syndrome that is persisting in our country. We are genetically very susceptible to diabetes, to other metabolic disorder. Next important problem, that we do not do proper care of our body. We are very bad people to do exercise. 90% of the population of India does not do any type of physical activities except going to office and others. Another very, very important thing is that we have to reverse this issue. To reverse this issue, there are plenty of ways. but most important is to catch them young. We have to go to the school and other areas where a large population of children either resides or being taught by the teachers. If we can give them a good amount of ideas about the food they should take, they should change the food of high carbohydrate, change it to fruits and vegetables. If in the canteen of the schools can be provided with only vegetables and fruits rather than chapati and loaves and all these things, I think to a great extent this food habit can be reversed and our population of diabetes can be at least decreased to a great extent. In fact, there is a very good work by Dr. Ramachandran from Chennai that if we treat the patient or started exercising in the school level at the age of 8 to 10 years and he is followed up for 2 decades, the response of this case was marvelous. The diabetic population, after this whole population goes, less than 1% only develop diabetes, whose both parents are diabetics, only that population develop diabetes only. Other all population has got a very good decrease in the development of diabetes in their later life. Another very important issue is those who have got a very bad economy in the childhood days, when they do not have money to eat foods, or what they have striving most of the time in their early life. When they come to the society of a affluent society, they take more and more food, and what happens? More carbohydrate, and they develop diabetes very easily. In fact, what happens in our yesterdays, I've got a large population of patients from Rajasthan, particularly Mebar, who are residing in Calcutta for decades together. When they in their childhood days, when I talk to the elder population, they used to have something pita like this. They used to have for one day with one pita they used to eat it up. Now when they are coming to Calcutta, having become more affluent, they are taking more carbohydrate, more ghee and all these things, butter, ghee and all carbohydrate foods. They are making more obese, they are becoming diabetic, they are becoming hypertensive, they are becoming high lipid and having heart, liver, kidney, all diseases after developing the diabetes.
Thank you, the APICON TV, for giving us the opportunity to host Dr. Professor Sibendu Ghosh and Dr. Rakhi Sanyal. With all the best wishes on this day of Bengali Shubho Noboborsho, we all the 3 Bengali wish you all the Shubho Noboborsho.
Thank you.
Thank you.